Welcome, colleagues, to this explainer. We're going to bypass the elementary concepts today and jump immediately into the clinical material. We are going to demystify complex biostatistics by anchoring them directly to high-yield clinical oncology scenarios, delivering an integrative mixed-block simulation calibrated strictly for a perfect 280-plus score. Let's get right into it. Our clinical pathway today covers 4 sequential steps: assessing disease risk, the rules of screening, confirming the diagnosis, and evaluating treatment efficacy. Section 1. Assessing disease risk and quantifying clinical exposure. We begin our journey by looking at exactly how we objectively measure the danger of a specific risk factor. In biostatistics, determining the specific danger an exposure presents requires analyzing the incidence of disease in an exposed group versus an unexposed group. For instance, consider a 10-year cohort study tracking thousands of adults to quantify the exact risk of a severe, toxin-driven, carcinogenic assault. Before doing the math, let's anchor this to the patient. We're looking at classic HPV-negative head and neck squamous cell carcinoma. This is the toxin-driven matrix. It's driven strictly by the synergistic destruction of heavy tobacco and alcohol abuse, which overwhelmingly leads to the mutation and inactivation of the TP53 tumor suppressor gene. Clinically, this frequently localizes to the larynx, oral cavity, or hypopharynx. It presents early with severe hoarseness or a non-healing oral ulcer. If you have an older alcoholic smoker with a hard, unilateral, non-tender cervical node, you must suspect SCC immediately. The prognosis is generally poor, often mandating highly morbid surgical resections. The best initial diagnostic step? A panendoscopy to locate that primary lesion. So, how do we quantify that specific risk? The crucial point mathematically is that attributable risk isolates the exact amount of disease directly caused by the risk factor itself. It literally strips away the baseline risk of the general population, showing you the true excess danger caused by the tobacco and alcohol. Let's run the numbers and see how this builds logically. First, you find the incidence in the exposed group, say 20 out of 2,000 smokers, which is 0.01. Second, you calculate the unexposed incidence, 8 out of 8,000 non-smokers, giving you 0.001. Finally, you simply subtract that baseline rate from the exposed rate, and the final attributable risk is 0.009. This isn't just a math problem, it's a precise, quantifiable measure of the danger of smoking in this cohort. It tells us that out of every 1,000 smokers, exactly 9 will develop this cancer specifically because of their smoking. Section 2. The rules of screening and identifying disease early. Once we rigorously understand the risks, the next step is finding the disease before it advances. Imagine you're in the clinic with a 62-year-old asymptomatic patient. He's worried about colon cancer because of his wife's recent adenocarcinoma diagnosis. He asks you, "Doc, what makes a screening test actually reliable?" Well, you need a test that casts the widest net possible. The absolute priority for any screening tool is high sensitivity. We have to minimize false negatives. This ensures that early occult cases are not missed, even if it means we have to accept a few false positives along the way. We want to catch absolutely everyone who might have the disease. It's a foundational concept. We screen to catch everyone with the disease using high sensitivity, and then we confirm to ensure only those with the actual disease get subjected to morbid treatments using high specificity. You screen broadly, and you confirm precisely. Section 3. Confirming the diagnosis and proving the pathology. Once a patient screens positive, we have to lock in the diagnosis. Let's test this concept using a clinical trial that evaluates a novel diagnostic tool for Hodgkin's lymphoma, comparing it against the absolute gold standard, an excisional lymph node biopsy. As a quick clinical review, remember that Hodgkin's lymphoma typically presents in a single localized node group and spreads contiguously. Diagnosis requires the immunohistochemical identification of Reed-Sternberg cells, which are distinct CD15 and CD30 positive B cells. Standard treatment is the ABVD regimen. Using the study data, we can construct the classic 2x2 diagnostic grid. This helps us visualize exactly where our true and false results fall. We have 432 true positives and 118 false positives, and on the negative side, 68 false negatives against 382 true negatives. When your patient sits across from you, looks you in the eye, and asks, "I tested positive, but do I actually have the cancer?" They aren't asking for sensitivity or specificity. They are asking you for the positive predictive value. To answer them, you simply take the true positives and divide them by every single person who received a positive test result. In this case, 432 divided by the sum of 432 and 118.
The result is 79%. This means that 79% of the patients who tested positive truly have the disease, while the remaining 21% are facing a false alarm. And remember, positive predictive value shifts based on the prevalence of the disease in your specific population.
Section 4. Evaluating treatment efficacy and analyzing the outcomes. Finally, our pathway reaches the treatment phase, where we must rigorously evaluate if our interventions actually work or if the data is deceiving us. Consider this classic board exam trap. A new screening biomarker is offered to the public, and soon after, survival time for amyotrophic lateral sclerosis appears to increase by 2 months. Did we actually improve their outcome?
Absolutely not. This perfectly defines lead time bias. For a progressive, incurable disease like ALS, we merely started the stopwatch earlier because we detected it sooner. We didn't alter the natural history of the disease, and we certainly didn't extend the patient's life. Always be strictly on guard for this when evaluating screening claims.
Alternatively, when evaluating a genuinely successful intervention, like a novel statin, we look at the actual drop in event rates. Say the risk of a cardiovascular event fell from 12% on an old drug down to 8% on the new drug.
Notice the staggering difference in how we can present this exact same data. A modest 4% absolute risk reduction is mathematically equivalent to a massive 33% relative risk reduction. Pharmaceutical companies absolutely love relative risk, but absolute risk tells the clinician the true grounded impact on the population.
As we conclude this explainer, we must test your deep integration of these principles. I present to you the master case. A 48-year-old male marathon runner with absolutely zero smoking or alcohol history presents with a 3-centimeter, painless, fluctuant, cystic mass in the left lateral neck. Flexible laryngoscopy in the clinic is completely normal, showing no obvious masses in the larynx or oral cavity. What is the most appropriate diagnostic next step? Your options are A. Reassurance and follow-up in 6 months. B. Fine needle aspiration with P16 immunohistochemical staining and panendoscopy. C. Excisional biopsy of the mass. D. Empiric antibiotics for an infected branchial cleft cyst. E. CT scan of the chest. The trap here is exquisite. It relies on the fluctuant, cystic nature of the mass and the patient's pristine, healthy lifestyle to heavily tempt you into diagnosing an innocent branchial cleft cyst, option D, or opting for a simple excisional biopsy, option C. But the correct clinical execution strictly maps to option B. Listen closely. A cystic lateral neck mass in a 45-plus non-smoker is an occult, HPV-positive squamous cell carcinoma until proven otherwise. This is the viral matrix, driven strictly by the integration of human papillomavirus, overwhelmingly type 16. The E6 and E7 viral oncoproteins degrade P53 and RB respectively. This demographic signature targets younger patients with zero toxin exposure, strictly localizing to the lymphoid tissue of the oropharynx, like the base of the tongue or palatine tonsils. Because these primary tumors are incredibly small and exquisitely sensitive to primary chemoradiation, surgical morbidity can often be radically de-escalated, and survival rates are drastically higher than HPV-negative tumors. Therefore, you absolutely bypass simple excision. You forcefully mandate a fine needle aspiration to secure the P16 surrogate marker, alongside a formal panendoscopy to hunt down that hidden tonsillar primary. Numbers and presentations aren't just formulas and trivia. They are the foundation of how we safely and honestly guide our patients through their clinical journey, avoiding deadly traps. So how will mastering the math and the mechanisms behind the medicine change the way you communicate risk and hope to your next patient? Thanks for joining me on this explainer. See you next time.